Hi everyone, how's it going? I mean, if you can hear me and see me. You guys able to hear and or see me by any chance? Anyone all there that can respond? Just want to make sure you guys are able to. It's working okay. There we go. Thank you, Sadie and Valerie. Appreciate that. We'll start here in just a few minutes. Hey, David. Hey, Kadeen. Brielle. I believe this is our last class. Been pretty fast overall. I know, yeah, it's very strange. It'll be definitely a year for the books. So then, so this time we'll go ahead and finish up the PowerPoint, and then if we have any, we'll have some time probably left over to where we can ask any questions you guys have about exam stuff. Again, let me find your. Our test is going to be covering geriatrics, endocrine, nephrology, and OB-GYN. So, not too bad in terms of amount of content, I don't think. I apologize in advance if you hear any noises or anything. That would be my 4-year-old who's in the room with me. Had some challenges with childcare this morning, so she's been instructed to be very quiet. But as you might understand, 4-year-olds have troubles with all that, so we'll see. Hey, Tron. See like a little minion or something pop up behind me. That's who that is. Hey, Madeline. All right, well, 8 o'clock. Get the recording going here. And I don't see any questions up so far, so I think we're okay from that standpoint. So we can go ahead and continue on with our, Dave, I'm sure you can for sure. Again, that is something I have a lot of respect for people who can go through PA school with children. It is no joke for sure, I can imagine. But anyway, so we discussed our hormone replacement therapies. We talked about how we can use that to help kind of women with menopause or something like that. You can replace the hormones that they might be missing. Here we're going to be talking about. Actually, no, I apologize. We're just getting into the OB stuff. So we did all the pregnancy stuff. Now we're going to get into specifically estrogens and progestins and all that. So never mind. Now we're going to be talking about hormone replacement and oral contraception, all that good stuff there. So anyway, so we're going to talk about the menstrual cycle here, and this should look pretty similar to like when we talked about the androgens for male hormones. Pretty similar in terms of. Sorry, someone a quick question here. Someone said for the next prescription assignment, we're writing it as an inpatient RX or outpatient like we did last trimester. So this is going to be, let me just double check. I don't want to tell you something wrong. Yeah, so this is an outpatient med. So use the original outpatient medication order stuff, since that's kind of the context we're writing it in. So that's what we're going to do for that there. Thank you for clarifying. Anyway, so looking at this again, we have the hypothalamus releasing GnRH. That then stimulates pituitary to release LH and FSH, and then that will stimulate the ovary. And then we're going to find that our two primary hormones here are going to be estradiol and then progesterone. We're going to talk about their specific functions here in just a little bit. Both of these have the ability to feed back and inhibit this system. So you can see here how, for instance, if we wanted to do something like stop production of LH or FSH, I could do that by supplying exogenous estradiol, and that should shut that down pretty significantly. That'll come up when we're talking about things like, PCOS or something like that. So we'll see some, see that come up again. Typically what's occurring during our, say, normal sort of quote-unquote normal 28-day cycle here is you're going to see sort of different changes that are occurring during in terms of like the follicular development that's getting a mature ova ready to be released, of the endometrium that is getting ready for implantation and actual or implantation of the fertilized egg, so that way they can start the development process there for the fetus. And then we'll see our levels of things like LH and FSH go through certain consistent trends along with estradiol and then progesterone. So what we're going to see here is that during the first 2 weeks or so, things are going along. You're going to see kind of a general trend up in your estradiol. And then by day 14 is typically when you have ovulation occur, right? So this is when you get this big spike in luteinizing hormone. This is when that follicle that is kind of developed as sort of the main one releases its ova. That's when you can then start to see the development of that corpus luteum afterwards. And then afterwards, you're going to see the levels of everything sort of drop off pretty significantly from there. Estradiol might spike up again, but then really what's happening towards the last stages of the cycle is the progesterone starts to peak up. And then what you're going to find is that if no implantation has occurred, then we'll see levels of both estradiol and progesterone are going to drop off significantly, and that's what triggers that sloughing of the endometrial tissue, and then you get your period, right? So what we're going to see is when we're supplying hormones, we can try to mimic this as best we can. In some cases, we may not try to mimic this at all. We may just give consistent doses, but, for instance, when you see things like there's birth controls that are biphasic or triphasic, some of them will try to mimic this cycle more closely than if you were just to give like a consistent dose of medications throughout the time. And then we'll also see how, for instance, like a lot of our oral contraceptives have the last week is just placebo pills and sort of mimics this drop off in both progesterone and estradiol. So we'll get into more details on that and kind of see what that looks like in just a little bit here. So in terms of disturbances in ovarian functions, is very, very common and can be due to lots of different things. So it could be due to issues of tumors. It could be inflammatory issues. You'll see that several of them can be more minor and sort of self-limited, especially when you think about, like a lot of physical stress or emotional stress that can affect things like GnRH secretion. If your body is not in a state where it thinks it's ready to become pregnant due to like starvation or something like that, then yeah, you may see things like, amenorrhea and whatnot. I always think about like, young student athletes, how they sometimes complain of amenorrhea. And a lot of times it's related to just them being like very physically active. And again, their body's not in a state where it's kind of thinking like, hey, let's get pregnant right now, right? Which is, sort of the more natural state for it to be in during those childbearing years. But anywho, so we're going to see in terms of estrogens that estradiol is going to be the major secretory product of the ovary. You're going to find that in the periphery, you can convert that over into things like estrone and estriol. These are going to be less clinically relevant. So estradiol is going to be the main thing that we're going to be focusing on here. Interestingly enough, we can see that actual animal hormones can act kind of very similar to our natural hormones. So for instance, we have equine estrogens that have been used in the past. And so back in the day, we had things like equilinin and equilin. And the best way to get that was actually from pregnant mares. And the best place that they excreted that was actually in their urine, interestingly enough. So they would take this, purify it out, and then that's where they got the drug Premarin from, which basically stands for pregnant mare urine. Fortunately, nowadays we still have a lot of Premarin products that we use, but I don't think we have to go straight to the horse's mouth, so to speak, or I guess their bladder. But we can basically synthesize the hormones ourselves. So fortunately, we have a little bit nicer way. It's not like you're saying, here, drink this horse pee. That's not really whatever it was. But again, when you tell patients that, they may be less likely to want to take that medication. But now it's all synthetic, so it's all good. Anyway, so looking here, we can see that there's in the general development of our, progesterones and estrogens and whatnot, we can see here they kind of share a consistent sort of heritage in terms of the precursor molecules. You can see here, you can see androstenedione, which is a precursor to testosterone. This will be an important precursor to formation of estradiol. So that enzyme aromatase is going to be important for this to occur. So aromatase converts testosterone over into estradiol. We see here progesterone being sort of a even higher up in terms of that production there. So they all share a very common lineage here, and they all share that very similar sort of four-ring structure. It's just a matter of changing sort of what's on the periphery there, and that can change pretty drastically what sort of actions it's going to have on our cells. So this will be an important target in terms of, perhaps we want to drop estrogen levels pretty significantly. This is going to be one way we can do that, is by inhibiting this enzyme. But we're going to see anytime we're inhibiting this process here, we can do things like tip the balance and then have more testosterone, which may lead to certain side effects. So we'll see what that looks like in just a little bit here. In terms of synthetic estrogens we're going to be seeing available, we have things like ethinyl estradiol, micronized estradiol, estradiol cypionate, valerate, estropitate, and there's kind of a category of conjugated estrogens, which are basically estrogens that have sort of a conjugated group on them to help out with some of the pharmacokinetic principles. But basically, they're all going to be doing the same thing. They may have various amounts of potency, so you may see the doses are a little bit different. Some of these might be dosed in milligrams, some of these might be dosed in micrograms, but again, they can be dosed to where you have sort of equipotency between those, just depending on how you're dosing them. And our purpose for these is also important as well. So are we looking to replace what the patient might be missing, what they would normally produce, like with hormone replacement therapy, or are we looking to shut down the whole system, right? Are we looking to decrease the amount of LH and FSH that we're producing to prevent things like ovulation? So we'll see there's different ways we can use it based on the dosages we're using. So Christine is asking, aromatase inhibitors convert both estrogen and androgen. No, so the enzyme converts testosterone over into estradiol. So if I inhibit this, I'm going to have a lot less estradiol around. And I'll go over some specific drugs that do that later on here. Yeah. Anyway, so in terms of the kinetics here, one of the big things to know is that the estrogens typically get metabolized through the through the liver, and they can then be conjugated with something else that makes them more easily excretable in the bile. And it's interesting because this actually undergoes something we've talked about before called enterohepatic recirculation. So these conjugated estrogens will be spit out through the biliary tract. From there, you can see that bacteria in the gut can actually metabolize that back into the parent estrogen, and then you can reabsorb that. That's important because that extends the half-life of our estrogens, and you can see that it can be a concern, especially if you're giving a patient exogenous estrogens, to where, well, what if they can't recycle that as well because they're having severe diarrhea, or maybe they've wiped out the bacteria in the gut that would normally do that with antibiotics. And so that's going to be sort of the genesis for some of the drug interactions we'll talk about. Also in terms of things like, when to use backup contraception, if they're on, antibiotics or not. Like, you may have heard things like that before, and that's where some of this is going to come from, as we'll talk about here. So typically things that are taken orally are going to have a lot higher hepatic to peripheral effects in terms of the ratio here, because they go through first pass metabolism. They're going to see that can have some impact in terms of the side effects we're going to see that are more hepatic in origin versus some of the peripheral effects. And so what we can do is we can try to avoid that by giving some of these things via other routes, right? So if we give things vaginally or transdermally, you can mitigate a lot of the hepatic effects that you can see there, which can be beneficial. So how do the hormones work? Well, they work just like corticosteroids or androgens or anything else. Estrogens are going to be able to get down into the actual nucleus of the cell and can affect different hormone response elements, right? So different things that are responding to the estrogen, and that can change gene transcription. It can change protein production, and in different tissues, it's going to have different effects because these receptors are slightly different, right? Every cell has the same DNA, but they might have different proteins that are being expressed. Such that in the breast tissue, you're going to get different effects than you will in the liver than you will in the fat tissue versus the bone, right? And so we're going to look at some different responses there. And actually, we have some drugs that are beneficial because they can act as an antagonist on one tissue, but an agonist in other tissues. And so those are called selective estrogen receptor modulators, and we'll look at those a little bit later as well. So, as I mentioned, they're going to bind to these hormone response elements, and depending on which tissue, you may get different interactions there. So what do the estrogens do for us? Well, they do quite a few things, right? So, for instance, with female growth and sexual maturation here, you can see that, around the time of puberty is when you're going to start to see these developments of the sex organs. You can start to see the typical sort of, hair growth pattern, body fat distribution, things like this. Also kind of interesting is because you typically think about adolescent girls, they sort of, their height sort of kind of jumps up sooner than boys do because of, kind of when they start to hit puberty, but they also kind of stunt out a little bit. They are generally going to be shorter than the boys at the end of it because of the fact that the estrogen actually has effects on closing the growth plates. So they are kind of limited in terms of that, which I always thought was like interesting. Is like, why did girls get so tall all of a sudden, but then they kind of peter out, and then the boys will become taller, and some of it is related to the estrogen effect there, which I always thought was kind of interesting. In terms of the endometrial effects, estrogen specifically will help to develop the endometrial lining, getting it ready for eventual implantation with a fertilized embryo or a fertilized egg there. And so we will find that it's really important that you have the interaction between estrogen and progesterone, because this will help to regulate that regular bleeding and shedding of that lining if it's not needed, right? So that's why you see that spike of progesterone towards the end of the menstrual cycle, is because at that point, if no implantation has happened there, then okay, we don't really need this tissue. Let's go ahead and get rid of it. One of the things you're going to find is if you were to just have someone who had an intact uterus and you gave them continuous estrogens without any progesterone, you're going to see a lot of hyperplasia of that tissue. You can see abnormal bleeding because of this, and that can lead to things like endometrial cancer. So we're going to see, as a general rule of thumb, any patient that has an intact uterus, if they're on estrogen, they need to be on a progesterone as well. Now, that doesn't go the other way. They can be on a progesterone without an estrogen, but this is why we do this, because we don't want to have unchecked growth of that tissue, because you're going to get all kinds of issues in terms of bleeding and then potential cancer risk, right? Other metabolic effects we can see here include things like decreased bone resorption. This is why we really care about estrogen replacement in older patients, because we worry about osteoporosis developing. We can see here it can have effects in terms of serum proteins and your cholesterol. A lot of that has to do with the effects in the liver there. And even just normal function of the skin and blood vessels can be affected by estrogens as well. Madeline's asking, so children with gender identity disorder can end up shorter than their expected projected height if they start hormone replacement therapy at younger ages. I think it depends, and so that's honestly something I'm interested in, but I have not done a ton of research into it, because my understanding is that you would typically not start hormones until they would normally, because if you think about it, if someone has, for instance, like a pituitary tumor that was removed, and I've seen this a lot as well. I remember one time when I was volunteering in pharmacy school, we went to the School for the Deaf and Blind in St. Augustine. We're doing student intake, and we had to check in all their medications. And what's really wild is that a lot of the patients who were blind was due to usually some sort of tumor that, when it was removed, it affected the optic nerve. And so some of this was like pituitary tumors, for instance. And so basically you would find that you wouldn't start hormones like estrogen and progesterone on these patients until they actually developed, or until they would normally have puberty anyway, right? So around like the 11 to 12 sort of time frame there. So I think ultimately, if you did start hormones on those patients, so say you had someone who's born male who was transitioning and they're starting hormones at a relatively young age, I think that could potentially affect their height there, because again, their testosterone levels would be lower and their estrogen levels higher. So you'd say expect to see that potentially, but Again, that's a very interesting topic, and I think probably is going to be developing as time goes on, especially since it's such a controversial topic. I think in some ways too. Especially like when's the right time to start that stuff, and all that. So pretty interesting. Thank you for asking that. Anyway, so some other effects here we're going to see in the liver. This is a really important one here, the coagulation effects. And this is primarily, especially with oral hormones, you're going to see this, this enhanced coagulability. And this has to do with increasing factors 2, 7, 9, and 10, and decreasing the activity of antithrombin 3. This is why if you have a young lady who shows up in the ER complaining of chest pain, oftentimes you're going to see a PE developing there, or if they have a DVT or something, it's related to these effects here. So you ask them, do you take oral contraceptives, and do you smoke? Those are kind of the two big risk factors there. You'll see that. Again, very common story. Other things we can see as well, including affecting mood and libido, and also you'll see that there's some cross reactivity with other hormone receptors. So for instance, like aldosterone receptors, you can see a little bit of edema and fluid retention associated with this. That's why you can see weight sort of fluctuate with patients during their menstrual cycle, is related to the hormone effects in terms of what that does for fluid retention. And we'll actually see some drugs that can affect this and actually help out with that to some degree in just a little bit here. So kind of getting back to what you were talking about, Madeline, if we had someone who had primary hypogonadism and could not produce these hormones on their own, or specifically things like luteinizing hormone or follicle stimulating hormone, what we can do is try to replace that, right? So, and it could be other things. It could be things like, developmental failure of the ovaries, things like that. But basically, we'd start around the years 11 to 13. And this would start to stimulate the development of the secondary sex characteristics and menses, and help out the bone development and whatnot. And then eventually you'd see, once they have their first sort of uterine bleeding, then you can add on the progestin at that point. And that's going to help out to prevent that sort of unchecked uterine development of the tissue there. So kind of an interesting way that we can utilize that, which you're going to see a lot more frequently, especially in older patients, as they start to go into menopause and they start to have drops in their levels of estrogen and progesterone. Basically, we can, and again, all kinds of very typical sort of disturbances that happen here, vasomotor symptoms like those hot flashes that they develop, start to have irregular bleeding or maybe loss of their menstrual periods, genital atrophy. They can get things like dyspareunia, where they have, it's very painful during sex, vaginal dryness, itchiness, sleep disturbances, all kinds of stuff there. And also we worry about things like their bone loss because of fracture risk for these patients. Not only that, but with the loss of estrogen, we can see that they also will develop some of these atherosclerotic changes, because things like LDL start to increase as a result of loss of that estrogen there. Interestingly enough, we used to think that estrogens were cardioprotective, and we would use it specifically for that purpose. But we're going to see it's a little bit of a double-edged sword, because you also increase your risk of some other issues, right? So things like the clotting risk, things like breast cancer risk. So we'll look at that as we go forward here. So we're going to see that with optimal therapy, when we're looking at these patients, and I'll talk about different dosage forms and how we might use them differently, that you have to consider things like their cardiovascular risk for osteoporosis, breast cancer, endometrial cancer, all these various things here. We'll typically find, in order to miss out on some of those hepatic effects, we can use things like transdermal products or vaginal estrogens in order to get a lower risk for a lot of that. So you kind of think about it as like, well, what kind of are the major problems are they having? Is it that they're mainly having, vaginal dryness issues? We'll just use a vaginal hormone, and that way you get mostly local effects. You get a little bit of peripheral, but it won't be as severe as if you're taking something orally. That's going to be more systemic. But having systemic symptoms, then you may need to kind of take the good with the bad from that standpoint. And typically for these patients here, we're going to use the lowest dose possible in order to manage their symptoms, because we're just trying to replace what they're missing in order to kind of ameliorate some of these changes that they're experiencing there. Now, again, the rule of thumb is if patients have had a history of a hysterectomy, then they can receive estrogens by themselves, because we're not really worried about that endometrial hyperplasia. However, if they still have an intact uterus, then you need to use a combo of an estrogen plus a progestin, because that'll help to decrease the hyperplasia and that cancer risk, and it'll help out with some of the bleeding issues as well. So other things that this hormones can help out with from a replacement standpoint includes osteoporosis prevention and treatment. Of course, we know they need to get their calcium and vitamin D in. Estrogen is just going to help with that. But again, you think about people at the highest risk for fractures, and it's typically like thin, Caucasian smokers. They're inactive, not getting around much, and low calcium intake. This is older females. Those are kind of the people you think about as being most at risk for fracture. And guess what? Like, I actually have a family member who exactly fits this, and guess what? She she had chronic pain issues. Was going from sitting to standing and was not able to catch herself, ended up falling, had a vertebral fracture, 2 wrist fractures, doing better now. But again, this is a very common story. They say common things are common for a reason. But, and again, if we just need things like, if they're having atrophic vaginitis, topical preparation can be just fine, for those type of patients there. Other things we can do things like trying to suppress ovulation, especially in patients with like intractable dysmenorrhea. So we can try to use exogenous estrogens to try to shut down to some degree LH and FSH production, so it doesn't stimulate that ovary to develop, which can cause pain in some patients. And then overall, we can do things like suppress ovarian function to treat amenorrhea, hirsutism, and whatnot, because one of the things you're going to see is that LH and FSH will stimulate testosterone production, which then eventually gets converted to estrogen. But sometimes people will have excessive androgen production. So I think like patients like PCOS, for instance, by giving estrogens exogenously, you can shut down the LH and FSH, and that will help to decrease the testosterone production there, and that can help to alleviate some of the symptoms. So again, different ways we can kind of monkey with the system, so to speak, and try to decrease production from some of these hormones here. So, of course, they are not without their risks. So, talking about some of the adverse effects here, we're going to see that uterine bleeding is, pretty common here, especially if they're used by themselves in patients who still have an intact uterus, as I mentioned there. One of the things you're going to see that's really important is that any patient with abnormal bleeding, you have to rule out like scary stuff like cancers and whatnot before you start using estrogens in order to treat that, because again, it could be something that's stimulating that original cause of bleeding in the first place. But here, if we can use the lowest dose possible, that's always going to be preferred, because again, it'll have better side effect profiles if we can get away with that. But we'll talk more about that later. So we'll see that we can give estrogen cyclically, meaning we can give it to where it's sort of mimicking what would normally occur in terms of giving it, say through a day 1 through 21 of a 28-day cycle, and then give them a withdrawal period there that can occur. We can see we don't always have to do that. We can give continuous hormones, and we'll see some dosage forms that can do that, and so that'll make more sense here in just a little bit. But again, if they still have an intact uterus, give a progestin, and it prevents that hyperplasia. We do see that some patients have an increase in breast cancer risk with prolonged use of estrogen. In this case here, progestin actually does not reduce the cancer risk. That's only going to be for endometrial cancer. It's not going to do anything for the breast cancer. For those who have a high-risk history, we can use things like SERMS, which are those selective estrogen receptor modulators, which can act as an antagonist at some tissues and agonist to other tissues. And so I'll show you some examples of that in a little bit, but we save those for more high-risk patients. So if they have like a high-risk history of breast cancer in their family. I mentioned the endometrial carcinoma, so you give progestins in order to help prevent that. And then, interestingly enough, there's a product we used to use called diethylstilbestrol. And so this is something to where the moms were actually using this, but it wasn't causing cancer in the moms. It's actually causing this adenocarcinoma in the women who were born from those moms. So that was really kind of a unique thing that they were able to identify based off of good, sort of epidemiologic studies and whatnot. So this is something we don't actually use anymore, but that was a particular cancer risk that is not really a factor anymore nowadays. Other things we can see in terms of adverse effects, including nausea, vomiting. You can see some breast tenderness since it's developing that tissue more, hyperpigmentation. Interestingly enough, migraines is a side effect, even though for some people giving estrogens improves their migraines. So again, it's very much on a case-by-case basis there. Cholestasis can occur. This is mostly with oral products because, again, that is going through the liver first, causing more hepatic effects versus peripheral effects. Hypertension is going to be more so seen with that fluid retention, so this is more likely to occur with patients with pre-existing hypertension. And then we just use the lowest dose possible to help mitigate some of these things here. So Someone's asking, why is progesterone not protective of breast cancer? Because progesterone doesn't really have much effect in that breast tissue. There's not really, whereas with the endometrial tissue, progestins help to blunt that development of it, right? And that's why we end up seeing that progestins, they normally peak towards that latter half of that period there, right? So normally days, after day 14 is when you start to see that spike up in the progesterone, and that helps to blunt that over development of the endometrial tissue. So it has a natural sort of blunting effect with that. And the breast tissue has no such effect, so it really doesn't do anything. It's just you're going to have this unmitigated sort of stimulatory effect on the breast tissue with the estrogen that the progesterone just can't help with, unfortunately. So that's why that is. Oops. So what are our contraindications here? So if patients have a history of estrogen-dependent neoplasms, that makes sense not to give them more estrogen. I mentioned any undiagnosed genital bleeding. Liver disease is going to be a relative contraindication, but this is more so with the oral products than something like topical or vaginal estrogen products there. Any thromboembolic disorders, so if they're at a higher propensity to bleeding, this is especially with the oral products. You definitely want to be careful with that, since that can increase the risk for clots, especially if they're heavy smokers as well. Someone said, Pants Prep Pearl says usage of DES or diethylstilbestrol is a risk factor for clear cell cancer. Clear cell cancer and adeno the same? I'm not sure. I've never heard that. I don't know if I've heard that term, clear cell cancer, before. I guess I can look it up. Clear cell cancer. It says carcinoma. Yeah, I'm not sure. I was hoping Google would give me like the straight up answer. We're talking about renal cell carcinoma, but yeah, I'm not sure. But if it says it, I'm sure there's some link there as well. So, unfortunately, we don't really see any diethylstilbestrol use. This is something that was more of an issue. I think a lot of those patients that might have been affected by that are probably getting a lot older nowadays, if I had to guess. But yes, but it's one of those things that's still like an easy question to put on the pan, since it's a very sort of unique thing there. Even though clinically you're not really going to run into anyone who's using that product anymore, because we know the risk of it, which is interesting. But okay, switching gears. Let me go back to the PowerPoint. Switching gears here, we'll see with the progestins that progesterone is the main one that we produce here. And as I talked about before, it's a precursor to a lot of things like adrenocorticosteroids, like cortisol and aldosterone, androgens, estrogens, and it's produced in the testes, ovary, adrenal cortex, because it is a precursor to so many things there. We will find here that whereas with a lot of our estrogen products we administer exogenously, a lot of them all act the same for the most part. You don't see a lot of variability. Here, though, the progestins, it's a little more varied in terms of what kind of responses you're going to be getting, in terms of what kind of physiologic effects you're going to see, which is pretty cool, because some of them are going to have more or less of these ancillary effects here, right? So when I say AR, that means androgen receptor activity, meaning if you stimulate an androgen receptor, you're going to get testosterone-like effects. And then if you have MR, which is mineralocorticoid effects, this is going to be acting more like aldosterone. Remember, aldosterone causes fluid retention, gets rid of potassium, that sort of thing there. So, for instance, when you have things like norgestrel, this has, I have a table later that also kind of goes over some of these details as well, but it's something like norgestrel or levonorgestrel, which is just an enantiomer of norgestrel. They both have high androgen receptor activity, right? So if I had a patient who was taking this and all of a sudden they were complaining of things like, hirsutism, like maybe they had some like darker hair development on their upper lip or something, that could be related to the high androgen receptor activity related to this drug. So they may want to use something like norethindrone, which would have less androgen receptor activity, for instance, right? Or for instance, we can have something like drospirenone, which actually has anti-mineralocorticoid effects, which could actually help with like weight loss because it would cause you to have a little bit of a diuretic effect, and then anti-androgen receptor effects there, right? So again, you can see that depending on and again, when you're trying to select a birth control, if you look at the number of different dosage forms that are out there, specifically for birth controls, there's like as many as there are stars in the sky, it feels like, because they can change so many things. That they can change whether it's a biphasic, monophasic, triphasic. They can be continuous. They can change the dose of the estrogen. They can change which progesterone. That's another big component, which progesterone is contained in there. So it can be difficult to determine like which one your patient's going to respond best to. It's kind of like a trial by fire. Just say, okay, well, we're going to give you 3 months of this, see how you do. Come back, and if you want to switch to something else, we can try that. But I think over time, if this is something you're going to be prescribing with some regularity, you'll kind of get a stable of things that work best for your patients, and then you'll kind of get a feel for, okay, for this type of patient, go with this one versus this type of patient, I'll do this one, and you kind of just have to play and see how it works for them. It'd be nice if there's like always go with this one, but it's not so clear cut as that. You're going to see quite a lot fewer pharmacokinetic issues with progesterone than you do with estrogens. No hepatic effects to really speak of here. Nothing really interesting from this standpoint. So it's kind of a little bit simpler from than the estrogens you saw there. In terms of their mechanism, they do the same exact thing that the estrogens do. It's just a matter of, oops, I don't want to paste in email addresses there. What we're going to see is that it just depends on what tissue you're in terms of what kind of effects you're going to get, right? So again, if it's something that has androgen receptor activity, it's going to be affecting things like hair cells. It can be affecting things like the muscle cells, things like that, depending on whichever tissue it's being exposed to. Let's see, someone had a question. Someone said, what does little ER activity mean? It means less estrogen receptor activity. So it may have fewer estrogen-like effects than you would see with maybe some of the other ones there, right? Because again, there's a lot of crossover in terms of what it can interact with, because it is a precursor. So again, it has the ability to sort of interact with a lot of those different receptors there, right? The table I'll show a little bit later, I think will be more clear-cut in terms of what kind of side effects you're going to be looking for. That'll be more clear for you. So I'll show you that. Okay. So with the progestins, what we're going to see is that it has not a huge effects on lipids here. Interesting, you can see some increased basal insulin levels and better response to glucose. So it can maybe help out with some degree of insulin resistance, which is kind of neat. Here, you'll see that it may compete with aldosterone in the kidney, leading to more aldosterone being released. So that can have effects there in terms of causing fluid retention, or if you have something with like anti-mineralocorticoid effects, that may actually help to ameliorate that to some degree, which isn't nice. And then as we talked about some of the maturation and secretory changes that we see in the endometrium, especially during that second half of the menstrual cycle there, so after day 14 basically. We're going to see here that, again, the synthetic agents we have can have variable activity at these different receptors, and this can be useful to help kind of reduce some of the side effects we'll see there. Someone says, for the exam, should we know what different progestins have more or less receptor activity? Yes, and I'll go over some of that more in the table in just a little bit, so that'll be more clear here coming up in just a bit. Especially if it's something like unique, like if it has like anti-activity at one of these that nothing else does. That's kind of unique things to note there. So what do we use progestins for? Mainly for either hormone replacement therapy or for long-term ovarian suppression. So this is one of those things where for especially someone who is if they're of childbearing potential, then they have a uterus. They cannot receive estrogens by themselves, as we mentioned before, because of that sort of unchecked uterine growth. However, they could be on progestins by themselves, and that would be okay, because that would be enough to cause ovarian suppression, prevent things like pregnancy from occurring here. So you can either use it like large parenteral doses. So for instance, like a medroxyprogesterone acetate, known as Depo-Provera. So if you ever hear like the Depo shot they're getting, that's what that's kind of colloquially referring to. That's a shot you can do IM every 90 days. That can have some benefits because of the fact that if you had a patient who you're worried about compliance, that is kind of taken care of, right? Or if you have someone who may be lost to follow-up easily, this can have some lag time on it to where it may be effective for more than 90 days. So that can be another benefit from that standpoint as well. The downsides, though, you're going to find that with progestin-only contraception is that this leads to prolonged anovulation and amenorrhea. And you'll also find a lot more bleeding that occurs here, sort of abnormal bleeding, amenorrhea that occurs, and just a prolonged time to get back to normal ovulation. So for instance, if you had someone, I always like to take, my PA students into account because, some people have a very clear schedule for their future. They say, I'm going to go through PA school. I'm going to do that. I'm going to get married, and then we're going to get pregnant at this time, right? So if you have a plan in place, this is going to make that pretty difficult because of, especially if you're using an IM formulation that may have a bit of a tail on it in terms of the levels. You can see that they may delay that because they may not be able to get pregnant exactly when they want, right? Of course, lots of other factors can be affecting that as well, but you have more chances to run into difficulty achieving normal ovulation than you would if you're on a traditional estrogen-progestin combo. So that's one of the downsides you're going to see with progestin-only products, but we'll look at some other downsides as well in just a little bit. So you may see some blood pressure effects. This is mainly due to some of the aldosterone or mineralocorticoid effects there. And then if things have more androgenic activity, then that can lower the HDL. So that can be a little bit antagonistic with some of your estrogens there. So let's talk more specifically about hormone replacement therapy. And so this is more typically with your patients with menopause or something like that we'd be looking at. What are the approved indications? Well, this is going to be for things like moderate to severe vasomotor symptoms. So those, things like the hot flashes they're experiencing, the sweating they can get there, all that. It can also be used for a lot of the vulvar and vaginal atrophy. So if they're developing that dyspareunia, atrophic vaginitis, all of that can be treated for here. And then postmenopausal osteoporosis. Those are the main indicators for when you'd want to use hormone replacement therapy in these older patients. Someone said with the depot shot, can they do the IM injections at home, or do they have to go to the office every 90 days? They have to go to the office. I don't know if they do it at home. I'm not aware of that. I think mostly you want to have them come back in and that way you can do the injection there. Again, difficult for a patient to do an IM shot by themselves. Especially because you normally would do it in the deltoid, and you couldn't necessarily, guarantee someone else has the training to do that for them. So as far as I know, it would be in office. Sub-Q injections are okay for patients to give by themselves. You can train them up on that, but IM is typically done in the healthcare setting. Unless it's like a EpiPen or something like that, but that's more of a emergent sort of situation. Anyway. So what we can see here is we can use a combo of estrogen-progestin therapy. So this is good for patients who still have an intact uterus, as I've mentioned. This could be something to where they could get an estrogen and progestin every single day, so they'd have no withdrawal periods at all, right? So they have continuous exposure to the medications. Or in some cases, you may find that they can do something that tries to mimic what the normal cycle would be. So they could do something like having estrogen on days 1 through 25. They would have progestin added on towards the second half, that last 10 to 14 days, and then they could have a withdrawal period from days 26 to 30, right? They may have some withdrawal bleeding associated with that. That is more mimicking the natural menstrual cycle, so some women may prefer that. Really is on a case-by-case basis. Grace is asking, when I worked in family medicine, the patients with the depot shot would pick it up from the pharmacy and bring it to the office for administration. They never did it at home. Yeah, I think that makes sense. I think especially that helps from the office standpoint, because that way they're not having to keep the medication on hand, and they can kind of bill it through their insurance. So yeah, that does comport. So thank you for your perspective. I appreciate that. So we could do estrogen-only therapy, but this is going to be for patients who have a history of a hysterectomy, okay? And then it could either be continuous or cyclic, depending on, again, patient preference there. And then you could use low-dose oral contraceptives here, but for the most part, you're going to see this is kind of overkill because in order to kind of shut down ovarian function entirely, we're using much higher doses, and so that we really don't need that for hormone replacement therapy for these older women. It's typically much lower doses we're using because we're just trying to replace what they're missing, basically. So our different dosage forms include oral, which again are going to undergo first pass metabolism, which will stimulate hepatic proteins, can lead to changes in clotting factor production, all of that. So in order to get around that, you can do things like transdermal products, right? So either like patches, those are the most common things you can see there. Those would be preferred in women who have more of a history of hypertension, increased triglycerides, risk for thrombosis, cholestasis. That's definitely going to be much preferred as opposed, you can do some creams, things like that. Intravaginal is going to be better for just vaginal symptoms. So if the only thing they're really complaining of is dyspareunia, then using an intravaginal product can be totally fine for that, right? Now you still can see some systemic absorption of the estrogens. It just won't be as much as you would be seeing with like oral administration, right? Some dosage forms help to mitigate this. So instead of using like a cream or something, you could use like a vaginal tablet or a vaginal ring, and I'll show you what that looks like here in just a little bit. Now, going through these tables here, the point is not to have you memorize every single one of these necessarily, and all the product names and whatnot, or the doses by any means, but just to give you an idea of like how these different drugs are formulated and kind of what the different sort of patterns we're noticing. And the point of this is, again, because there are so many products that are out there, I at least want you to have like the concept of how we treat this as opposed to memorizing every single product that's out there. Because again, when you're working, you'll get a feel for like which products you're going to be using most commonly, especially if you work in OB-GYN. I just want to give you at least the kind of overview of the different ways that we can use these drugs as opposed to, getting in the weeds in terms of memorization here. But again, here's some examples of estrogen-only products. So you can notice here that a lot of these would be continuous estrogen, right? They're just either getting just a consistent dose per day. It's not like they're getting a withdrawal period at all. They don't change the dose throughout the month. They just get the same dose every single day, and that might be okay for patients who have a history of, for instance, a hysterectomy. This would be fine, right? Because again, you don't want to give this to someone who still has an intact uterus. Here's some examples of transdermal products, and again, just the number of products we have here is just mind-boggling in some cases. Some of these may be applied just once weekly, twice weekly. That can be useful for things like compliance. So kind of similar. Have a depot shot's good for 90 days. This could be good to help cover them for the week, for instance, right? Transdermal gels you can use, transdermal sprays, a lot of different dosage forms that are available for this purpose here. So here are some ones. Let me see here. So these are the vaginal estrogen products, right? So these are ones that actually be inserted intravaginally. So again, this may take some more education in terms of helping them to know how to apply it and things like that. But for instance, you can see here, some of these are designed to be given more cyclically. So for instance, here with this conjugated estrogen or Premarin vaginal cream, they'd be using basically the product for 21 days, and they'd have 7 days off, for instance, right? So that could be one way they can try to get sort of that normal sort of cycle going there. Madeline's asking, can intravaginal estrogens be used if there are lesions present, herpes flare-ups? As far as I know, there's no contraindication, but I can look it up real quick. Let's see here. Well, this is boring to you guys, but I'm gonna look over contraindication. I'll put the screen up here in just a second. Yeah, so I don't see anything here. So I'm looking at the warnings and precautions, right? And yeah, nothing here is really, and again, a lot of these are kind of comporting what we saw already in terms of some of the effects we mainly see there, but I don't see any issues in terms of anything like that. Yeah, so I think it's okay. I don't think you're going to see any issues in terms of that. But yeah, good question. Not something I had thought about before. And again, I don't deal with a lot of these products. My patients generally come in a much younger sort of variety since I work in pediatrics. So again, your mileage may vary with this when you see it out there in the real world. If you're working like you do your OB-GYN rotation, for instance, you may see different things. But this is generally, I've not had anyone ever come back and say like, you taught us wrong about this stuff. So I think it mostly holds true. Here's an example of an E-string, which is actually a vaginal ring that can be placed in for 90 days at a time. And so this is basically a ring that has the drug basically sort of impregnated into it, so to speak, and it slowly releases the drug over time, and that helps to limit some of the systemic absorption. So if you really are trying to limit some of those systemic effects, this may be one good way to do that. There's a vaginal tablet that can also do sort of the same thing there. Again, the dosing is going to be variable depending on the products there. So here's an example of what the primary vaginal cream would look like. Again, they can basically, they'll have an applicator here that they could use to place the drug into the applicator. Depending on which dose they're going to get, they can drop to the various levels and then insert that intravaginally and then insert the cream. Obviously, cleaning is very important to make sure if they're going to be reusing this to clean it, to make sure they're not going to have any vaginal infections as a result of using this. May seem pretty intuitive, common sense, but again, common sense is not always so common with your patients. And then here you can see the E-string. This is that vaginal ring. Just place this up against the cervix and get that local sort of release of the drug to help out with those vaginal symptoms there. And this is one of those things, if it comes out, they can just place it back in. There's no problem from that standpoint. We'll see some other ring products here in just a little bit. To switch gears, here are the estrogen-progestin combinations here. So you can see, again, some of these will be more cyclical. So for instance, this one can have estrogen alone for the first 2 weeks and then add on the progestin for the last 2 weeks. Now, again, how do they keep patients on track? Well, that's why they usually come in those blister packs, so they can see, okay, the first day of the month, I do this one. The second day, I do this one. And that is an aid to help keep patients consistent and make sure they know kind of where they're at in terms of the month. We'll talk more about those packs and things when we get into the contraceptives here in just a little bit. Again, you can see continuous ones, cyclic ones. It really just depends on what the patient's preferences are, kind of what your experience has been, working with them, things like that in terms of which product you'll select for them. Again, these are good for patients who still have an intact uterus. They need the progestin product there. You have transdermal products as well that are available, so it really just depends on the patient history and what's going to be most appropriate for them in those cases there. You could do progestins by themselves. I see this less often for hormone replacement therapy purposes, because typically they're having issues. They kind of need the estrogen component of it. But if you had someone who's really high risk who could not receive an estrogen, then this could be something you could do as an alternative. Something like medroxyprogesterone could be used in those cases there. So anyway, other things we could use for the vasomotor symptoms of menopause that are non-hormonal drugs include things like our antidepressants, anticonvulsants, and antihypertensives. So these drugs can all kind of help out with this. Things like SSRIs, things like your SNRIs like venlafaxine or desvenlafaxine can help out with this. Gabapentin has been known to help out with these things as well. So this could either be used in someone who hormones were contraindicated or they didn't want to take the hormones. This could be used as an add-on potentially, or maybe they already were on some of these, or for instance, if someone was taking, someone had a history of depression or something, never been treated for that before, but they also have menopause. This could be a good kind of killing two birds with one stone sort of treatment there, which is kind of nice. So good to know. Okay, then we have our oral contraceptives. So this is going to be basically where we are trying to shut down ovarian function in order to prevent ovulation from occurring. So that way a pregnancy does not happen. Not only that, but we're also going to see that by applying these hormones, we're going to be causing changes to the vaginal tract that sort of make it inhospitable for implantation to occur. Things like cervical mucus changes and things like that, fallopian tube motility, things like that are going to change. So that way it's going to be more difficult for a sperm to actually come in and implant with the egg. Or fertilize the egg and then cause implantation to occur. So anyway, so different ways we can do this. So with the combo of estrogens and progestins, we can either do monophasic, which is going to be sort of a constant dose of both estrogen and progestin throughout the entire cycle, on days 1 through 21 basically. Most of these that are going to be a monthly based product are going to have placebo pills on days 22 through 28 basically. The reason why we do placebo pills is to make sure the patients are still taking something every single day, so that way they're in the habit. I always wondered that when I was growing up. I was like, why are these pills a different color? And it's like, oh, they're placebo. And I'm like, well, why did you take sugar pills? But it makes sense, because if they're taking something every single day, it helps keep them into the habit. Because we will see that in terms of preventing pregnancies, these drugs are very good at what they do. However, if patients are not taking them like they're supposed to, then mistakes can happen, right? And so if that is not their goal, or if their goal is to not get pregnant, then they want to make sure they're taking them consistently. We could also have biphasic and triphasic products. This is where you can have changes in the dose either once or twice throughout the cycle, and that helps to mimic what a more normal cycle would occur in terms of hormone levels there. So that can be useful because that can help to limit the total amount of hormones they're receiving throughout the month, which may be useful for preventing or treating some side effects. And I'll talk more about that here in just a little bit. Or the alternative could be just continuous progestin-only therapy. Now, again, I say hormonal contraception. Not everyone is using these for contraception. They could be using these for lots of other things, varying dysfunctions. They could be using it for, if they are, female to male transitioning, things like that. Lots of different functions. But I'm mainly going to talk about it in the context of contraception because I think that is probably the lion's share of the use of these drugs here. But anyway, so again, they're going to help to suppress production of LH and FSH by feeding back and inhibiting the hypothalamus and the pituitary gland and prevent production of those hormones. So that way we'll see less development of the follicle. We're not going to get that mature egg being released. We should not have, again, a vaginal tract that is hospitable to a sperm and causing fertilization to occur there. So as I mentioned, you're going to see things like changes in the cervical mucus, motility and secretion of the uterine tubes, and overall decreased likelihood of conception and implantation. We're going to find though that if you're using a progestin only, it does help out with some of those sort of environment changes, but it doesn't always reliably inhibit ovulation. That can be a bit of a challenge there as well. You'll see the failure rate for progestins is going to be a little bit higher than using the combo. So again, if you have to, there are plenty of reasons to use progestin-only products, but just know that the failure rate and some of the side effect profiles are going to be a little bit worse than using the combo product there. But again, a lot of this is very patient-dependent. Some people may respond great to one drug, and then you'll have some people that respond terribly to the same drug. It's going to be very dependent. So as I mentioned, they're going to see depressed ovarian functions. They're going to be smaller, which is good if you have patients like PCOS, for instance. You're going to find that typically most patients will go back to their normal menstrual patterns once it's discontinued. So there's not a long time for your body to sort of get back to normal. Majority of people are going to ovulate during the first cycle. By the third, about 97% have. So most people have. However, some people may remain amenorrheic for several years. Right? It's rare, but it can occur. And obviously, if they're taking progestin, then that's also going to be more likely to see the amenorrhea or anovulation occurring there. So, also with the uterus, we're going to see things like hypertrophy and polyp formation, thicker, less copious mucus. Again, all that helps out with preventing sort of a hospitable environment for the sperm to go and cause implantation to happen there. With the breast, you can see things like enlargement and suppressing lactation. You'll see prolactin levels will typically dip in association with giving these exogenous hormones here, which makes sense because typically, if your body's in a state where you're trying to suppress, you're producing all the estrogen and progesterone, and your body kind of thinks it's pregnant already, so it does would shut down lactation since you don't want to be breastfeeding during that time anyway. So it's kind of a natural sort of change you'll see there. But other things we'll see in terms of hematologic effects, and this is mainly due to the estrogens, is this increase in those clotting factors there. So that's where you see a lot of the thromboembolic concerns. And again, that's like a classic board style question and whatnot. Young lady shows up to the ER, history of oral contraceptives, and showing up with chest pain, PE all the way, right? Because of the effects on the clotting factors there. We mentioned you can see some hyperpigmentation. This is typically, especially for patients with darker complexions, that they have more UV light exposure. This is more likely to occur there. Somewhat reversible, but it may take time once they stop the hormones. And then certainly we can see changes in the skin related to some of the androgenic effects of the progestin, which can worsen acne. Now, for some people, you'll find that their acne will be improved by using oral contraceptives because it may be helping to shut down their own testosterone production. Just know that some of those progestins, though, can actually worsen that. And again, it goes into the variability that you're going to see in these products here. As I mentioned, in terms of uses, contraception is one of the most common ones you can see here. If everyone is taking everything exactly like they're supposed to, you would find that only 0.5 to 1 pregnancies would occur per 100 women years, which I always think it's funny to think about a half a pregnancy is what does that look like? It's just the top half, the bottom half of the baby? I don't know. But with routine use, we typically see, if you followed 100 women for 1 year, you'd have between 5 and 12 pregnancies, right? So these products are not perfect, especially when you introduce the human element into that. So that is an important consideration. We'll talk about what to do with missed doses here in just a little bit. So you always want to consider too, like what could be other things that are affecting the medication. So for instance, enzyme inducers that could increase the metabolism of the estrogens, like phenytoin, can reduce those levels. Things that disrupt enterohepatic recycling can also reduce estrogen levels and can increase your risk for ovulating. So that is always going to be something that can kind of consider there. Christina's saying, why does enlarged breasts would suppress lactation if the body thinks they're pregnant? Pregnant when the milk be produced? Well, not during pregnancy, right? So normally what you're going to find is that during the pregnancy, you can it'll suppress lactation because you're trying to develop this baby inside of you. You're not trying to feed something else necessarily. So that's kind of why you see that to some degree. Because again, if you think about like hormone changes that occurred during pregnancy, like you find the estrogen-progestin levels are usually pretty high, usually as a result of either like the corpus luteum or due to the actual, I'm trying to think, what is that thing they produce along with the baby? I'm completely losing my mind here. I apologize. I'm trying to think. Placenta. Thank you, me, for remembering placenta, which is an easy word. So the placenta will be producing a lot of those hormones as well. So that can have a suppressive effect on the prolactin. Versus when you've had that baby, you typically see a dip down in those hormone levels, estrogen, progestin, and that's the prolactin will pick back up, and that then stimulates, the breast milk production and whatnot. So again, it's all a matter in the state of like what the body thinks is most important. If it's pregnant, it probably wants to develop that fetus as opposed to feeding a baby or something like that with the breast milk. So it seems kind of odd, but and again, it's just that the breast tissue responds to estrogen. I mean, that's why the breast developed during puberty, is because it's responding to that estrogen. So again, the actual breast cell hypertrophy is sort of not necessarily tied one-to-one with milk production and all of that. So that's as far as my understanding goes. But if you have a different thought, let me know. We can kind of talk about it. But good thought. Anyway, so with endometriosis, this is really used to help out with this. So we can use, you may find that, as I mentioned, estrogen alone may be sufficient to sort of alleviate the pain here, but because they still have an intact uterus, you have to have the progesterone on there as well to help out with that. And again, if you're using it for like a non-contraceptive purpose, using the lowest dose possible is always going to be beneficial here. So overall, if you can limit the amount of hormones they're receiving, you're generally going to help to limit some of these side effects. So what are we expecting to see in terms of side effects? You can see some nausea, breakthrough bleeding, edema, mastalgia makes sense because, again, you're causing development of the breast tissue there, or causing hypertrophy. You can see that this is typically going to be seen with too much estrogen, so you can either use smaller doses, or if we have progestins with more sort of androgenic effects, it can help to sort of limit that to some degree. With headache, we mentioned that for some people it can help their migraines. For other people, it will help to decrease their migraines. It just really depends on how they're going to respond to that. Typically, if anything, you may see a risk for cerebrovascular accidents, especially if they have a previous history of like hypercoagulable state, although that is quite rare. And then certainly if you saw migraines all of a sudden started while taking the hormones, then that's probably a good sign. You probably need to stop the medication there. Try to figure out something else. Now with withdrawal bleeding, this may fail to occur. And this is kind of why you'll see in a lot of cases when you first prescribe an oral contraceptive to somebody, you do it for 3 months at a time. Like you do it for the initial 3 months. Because you may find that some of the side effects that occur during the first month have cleared up by the end of 3 months because the body's kind of getting used to having this new kind of level of hormones around, because for things like withdrawal bleeding, it may fail to occur with the first time they're on that cycle, and that could be problematic because they may think that they're pregnant all of a sudden. They don't necessarily need to go out and get a pregnancy test, although I think a lot of people will probably be skittish enough they probably go do that anyway. But we can see here that if they're having failure of withdrawal bleeding, they can try other agents and see how they respond to that. Other things we can find, breakthrough bleeding is going to be more likely if you're just using progestin-only products, and in lower dose preparations as well. So that's going to be kind of the double-edged sword there, is you want to limit overall hormone exposure if you can, but you may see more bleeding associated with that if you're having low estrogen levels or if you're just using progestins by themselves. Now, one thing you can do to help out with that, to try to mitigate the, try to not increase the total amount of hormones they're going to get is by using a bi or triphasic product. So that way, whenever they would normally be getting that breakthrough bleeding, you've modified the estrogen dose. And I'll show you some examples of what that looks like in terms of how those estrogen doses change throughout the month with those tri and biphasic products there. So that'll make more sense in a little bit. With weight gain, you see this more likely with more androgen-like progestins. If you can switch to something that is less androgenic or has anti-mineralic corticoid effects, that will be useful. Or dieting can also help out with this as well. We talked about increased pigmentation. This is actually exacerbated by people with a vitamin B deficiency, so you can make sure they're getting their vitamin supplementation. That can help out with that. It can be reversible if it's really problematic to the patients, but it can be slowly reversible there. And then, as I mentioned with the acne, this may be worsened if they have more androgen-like progestins on board. However, large dose estrogens may actually improve it. So again, a lot of this goes back to figure out, okay, well, is it more of an issue, the progestin that we're using? Let's try switching to a product with a different progestin, see if they respond better to that. Hirsutism tends to be more aggravated by more androgenic progestins, right? So you may want to switch to an anti-androgenic one if patient's experiencing that. You may see some ureteral dilation that can happen here. This is kind of similar to the changes that you would see during pregnancy. So things like bacteriuria may be more frequent. So if you had a history with frequent UTIs, this may be more likely to occur. So you'd want to watch out for that. Vaginal infections tend to be a little bit more common due to the hormonal changes here. And then amenorrhea is somewhat common. Again, it can be dependent on the patient here, but this is more seen with patients who had menstrual irregularities prior to taking the product. So again, they're just more likely to have it while they're taking these as well. Some of this may be related to things like having prolactinomas. So that'd be one thing to look into to see if that could be causing some of their problems there. And then severe risk include things like venous thromboembolism. Obviously, this is an estrogen-related problem. And we'll see that as soon as they start taking the drug, their risk is increased, and it will remain consistent as long as they're taking the product. And usually that risk is going to go back down to baseline as soon as they discontinue with that within about a month or so. Obviously, if they have a hypercoagulable state, they're going to be almost contraindicated from getting this. And again, it's just an estrogen-only problem. So you could switch them over to something like a progestin only, and that would be totally fine. Increased risk for things like MI. This is related to those that had an increased risk anyway. So if they had a history of diabetes, hypertension, some of this is related to things like changes in their lipids. You had an androgenic progestin on board. If they're a smoker, this can also worsen that. So just things to consider there. Again, if you have like a typical young, healthy patient, this is probably not going to be a big risk. But for older patients who have risk factors, this might be a concern. Risk for cerebrovascular accidents is typically seen in those greater than 35 years of age, especially if they have a lot of risk factors. And then from a gastrointestinal standpoint, you can see things like cholestatic jaundice. This is more so with oral products, not so if you were seeing more it's like a vaginal product or a transdermal product potentially there to consider. Generally, this will resolve with discontinuation for the most part. You can see some mood changes that occur here, like changes in libido and mood. For some patients, you will see that this can improve their mood. For others, it will worsen it. Again, very dependent on the patient there. Some may even require discontinuation because they feel so miserable while they're taking it. And then overall, you're going to see reduced risk of endometrial and ovarian cancer. However, you can see that lifetime risk of breast cancer does not appear to be appreciably changed here. And then those with HPV do have an increased risk for cervical cancer. So again, depending on if they've been vaccinated previously with Gardasil or something like that, that may be a non-issue, but it just depends on the case there. So this is that table I was talking about with the different progestin activities here, to kind of give you an idea of which ones are going to be more androgenic versus having more estrogenic sort of effects here. So again, if you have someone who's taking something like levonorgestrel is having a lot of like hirsutism, then you probably want to switch them over to something like ethanoyl diacetate, or you could use something like norgestimate or even drospirenone, which has no activity whatsoever. So those would be things you'd want to kind of consider there. Have an idea for which ones are like really strongly androgenic versus strongly estrogenic, things like that would be kind of points I'd want to kind of key in on. So our contraindications here to use include things like thrombophlebitis, cardiovascular, cerebrovascular disorders. A prior history of that, probably wouldn't want to aggravate that by adding on estrogens. Any unknown causes for vaginal bleeding, got to rule out the scary stuff first. Any estrogen-dependent tumors, they have heart failure since that can cause some edema, it can worsen that. If they have not undergone the epiphyseal closure yet, you may want to be hesitant about using these since that can cause a premature closure, maybe growth stunting. If they have hepatic enzyme inducers on board, be really careful with oral products since that can reduce the doses of estrogen and make ovulation more likely to occur. And then obviously they are on antibacterials. You want to be careful there because since that can disrupt that enterohepatic recycling of the estrogen, that may increase their risk for having ovulation happen there. And if they're pregnancy, or if they are pregnant, then obviously they don't need the hormones because they will be producing plenty of hormones themselves. So for progestin-only contraception, this is going to be good for patients who estrogen administration is not going to be recommended. So they have a previous thromboembolic disorder or something like that. It'll be nearly as effective as the other agents. It has a slightly higher failure rate if taken perfectly, and has a higher incidence of abnormal bleeding. Typically, this will decrease with time as the body kind of gets used to it, and you may have a delayed return to ovulation, as we kind of mentioned before. So a couple of certain circumstances we'll talk about here before we get into all the products. We can see that postcoital contraceptives is something to consider as well for your patients. It's kind of considered the morning after pill. This would be something they could either be estrogen by themselves, progestin only, or sometimes a combination. These are really effective at what they do in order to prevent an unwanted pregnancy, but it's really important to make sure that the time frame is being met here. The longer they wait, the more likely that they are going to kind of miss their window of opportunity and a potential pregnancy could occur here. Note that Florida is a state where if a patient needed to, they can go to the pharmacy and get Plan B, which is levonorgestrel, which is why I highlighted it here. They can get this without a prescription, right? So that does help to increase access for those who might not have the ability to go to the doctor or for whatever reason that can be useful. One of the things to consider, though, is that while it is quite effective, they do cause a lot of nausea and vomiting because typically it's very large doses of hormones kind of being all given at once in order to help make sure that no implantation occurs. And so a lot of vomiting happens here due to the dose. And so if you can give like an antiemetic beforehand, that can be useful if they're coming to see you beforehand. You may give them a dose or two of Zofran. Generally speaking, if someone vomits something within an hour, they may need to retake it. Otherwise, if it's been more than an hour and they vomit, then they're generally pretty okay to go. So other benefits of hormonal contraception include things like reduced risk of ovarian cysts, endometrial cancer, ectopic pregnancies, iron deficiencies. Typically, if they have like high, heavy bleeding during menses, this can help to reduce that to some degree and help out with iron deficiencies. Acne, hirsutism, a lot of things can be beneficial here. However, keep in mind some of this may be worsened depending on which progestin you're using. So like acne and hirsutism especially. So typically we're going to start with a combination pill for most patients, and we try to use the lowest effective estrogen dose possible. Most of the ones we're going to see here include the estrogen ethinyl estradiol. That's typically just what we use. And we try to find what's going to be an acceptable level of side effects for the patient. Tell them what to expect and have them kind of report back to us. And we give them a 3-month supply typically. They can kind of go through 3 cycles, see how it's going to affect them, see what kind of gets better or gets worse with time, and they can come back and see if we want to kind of re-up on that or try to switch to something else. So in terms of starting oral contraception, normally they want to start on the first Sunday after the onset of menses. The reason for this, why they do Sunday, and again, this is a lot of stuff I never knew when I was like, before I came to pharmacy school, and I just thought this was all just like, why do you give it on Sunday? I don't know, you just do it on Sundays. The reason for that is because it typically avoids withdrawal bleeding on the weekends. So that way, if they start to have their placebo pills on a Sunday, they should then start to have their withdrawal bleeding throughout the week, and then by the time they get to the weekend, most of that bleeding has been resolved. Okay, and they'd be starting on that next Sunday on the new pack there. However, if they don't really care about the weekends or it doesn't matter, then there's nothing special about a Sunday. They can start whatever day they want. Typically, if it's post-pregnancy, they do about 3 to 4 weeks after delivery. They can start up a new oral contraception. Do not rely just on breastfeeding for a natural form of contraception, because that's how you get a second child. Just FYI, not that I would know from experience or anything. But and then if they had a recent abortion, they can do it the first Sunday after that and kind of get them back onto a normal cycle with that. When you may want to consider using alternative methods of birth control. With the initial cycle, some people feel that it might be worthwhile because, again, you're kind of introducing this new hormone. Perhaps ovulation's not been necessarily inhibited all the way. That's controversial. There's no data saying that you absolutely have to do it. And again, we're never going to have a study where we're going to be having 100 women in two groups and saying, okay, we're going to give you these different conditions and see who gets pregnant, who doesn't. Like that's not very ethical. We'll talk about missed pills here in just a little bit, but we're going to see that, especially with the lower doses of estrogen, you're more likely to run into issues with that. So we'll talk about that in just a little bit here. And then again, some people are considering, if you have severe diarrhea or antibiotics, that can help to limit that recycling of the hormones. Or the estrogen specifically can lead to ovulation. So you may want to consider recommending backup contraception during that time. However, if they're having severe diarrhea and antibiotics, it might not even be an issue if they don't want to have sex. So it's something to consider as well. Yep. That is one way to find out, David, that is, don't rely on anything natural to prevent pregnancies. We have to rely on modern science to keep that from happening. Anyway. So with missed pills, what do we do? So if they remember that day that they missed a pill, then they can just take it as soon as they remember, and that's totally fine. They'll be back on track. If they miss 2 pills, the way they can do is actually catch up by taking two pills for 2 days in a row, and then that will get them back on their normal track in terms of where they're at in the month, and they generally should not have any issues in terms of having ovulation occur. If it is 3 or more days, then they can say, okay, that's too many. The levels have been too low for too long. Let's go ahead and just DC the rest of the pack, and they can restart a new one on Sunday, right? That way they can kind of start over with a brand new cycle there. So that's kind of the recommendations for that. If they miss a period with their first cycle especially, and they don't have any missed pills, they probably don't need to get a pregnancy test right after the first one, but maybe after subsequent ones, they can consider getting a pregnancy test done. But again, for the most part, you have to ask about how compliant they're being, if they're actually taking, everything that they're supposed to. There is a concept called honeymooning, which I always thought was like pretty wild, because I didn't even realize you could just like reschedule menses. I was just like, oh, that's just something that just happens with the cycles of the moon, right? And little did I know that we can actually reschedule these things. So if you had something like an important event coming up, like graduation or honeymoon or wedding or whatever you have coming up, you don't want to have withdrawal bleeding occurring during, you can just continue taking active pills until after the event is done. So basically, if they're coming up, say the wedding's coming up this weekend and they're coming up to the placebo pills, they could just skip those placebo pills, go into the next pack and continue taking active drug until they are finished with that. And then, they can finish out that pack, have the withdrawal bleeding and then get back on their cycle there. So, there's no need necessarily for like rest periods. People can stay on these for decades potentially, not have any issues. However, if they are desiring to become pregnant, you may want to wait up to like 3 cycles or so before. Some people say wait, 3 cycles, but again, the return to ovulation happens pretty quickly for most people. So that's going to be kind of a controversial thing. Before you start to get really worried, I'd say give them 3 cycles or so before they can say if there's going to be something going on or not, Someone said, what happens if someone takes Plan B, throws up within 1 or 2 hours, and takes it again, but they really didn't need to? Can they have any adverse reactions from taking too much? Generally, no. I mean, that's really the biggest thing you'd worry about is just that the nausea, vomiting. But again, like I mentioned, if it's within an hour, then I would say retake the dose. But if it's within 2 hours, you're probably fine at that point. Anything past 2 hours, so it's had time to get past the is down to the small intestine by that point there, so really wouldn't be concerned after an hour. But yeah, you may just see more nausea, vomiting, but other than that, I really wouldn't expect to see any other issues associated with that necessarily. So not that I'm aware of, at least. So if they're having breakthrough bleeding, you kind of look to see like where the bleeding is actually occurring. Normally during the first 3 months, it's kind of giving your body time to sort of figure itself out, and it will generally resolve. However, after that first 3 months, if they're still continuing on the same product, you can kind of manipulate the pills that you're using based on the location of the bleeding. Typically, if they're bleeding on the first 2 weeks, it's related to an estrogen deficiency. So you could try switching to a product where they're getting more estrogen during the early parts of the month. And then if they are bleeding on the third week of the month, then it may be related to a progestin deficiency. So you may need to try something a little bit higher dose from that standpoint. So you can kind of modify that in order to try to deal with some of that bleeding that's occurring there. Now looking at medroxyprogesterone acetate or Depo-Provera, this is a shot that is again given every 90 days or so. The duration of action is actually a bit longer than that, so it can still be working for up to 4 to 6 weeks afterwards. So that's why it's good for patients who may have issues in terms of for instance, compliance issues or something like that. I always think about this situation if you had someone with like really severe mental health issues, like schizophrenia or bipolar disorder, who are on medications that are like really teratogenic, and it would be a big issue if they got pregnant. This might be a good option because this sort of enforces compliance. You're not necessarily relying on the patient to know to take their pill every single day. So that could be something that may be a consideration, or if they just don't want to think about taking the pill every single day, this might be perfectly fine for them. Just know that amenorrhea is pretty common with this, and you can get sort of irregular bleeding patterns associated with it, just because you're lacking that estrogen effect. So other products, let's talk about our IUDs, or intrauterine devices. So this is basically things that would be placed by the provider directly into the uterus. And so here's an example of a levonorgestrel based one called Mirena. And the benefits with these is that, again, it's sort of ensured compliance, and they last for quite a long time. So this one could last for up to 5 years. And if the patient wanted to get pregnant, then they could just go back to their OB-GYN, have it removed, and then they're generally are good to go within a cycle or two. So the way that this is working is not necessarily working systemically to suppress ovulation, but it's working locally to try to make sure that it is preventing the environment from being so hospitable for pregnancy to occur. So again, the benefits here also is you're limiting a lot of the systemic exposure of hormones. You're not going to see like the clotting risk associated with this, because it's just a progestin being leached out locally here in the uterus. So that's kind of one of the major benefits from that standpoint. Here's an example of something called a NuvaRing, which is an intravaginal product that can be placed, and this would be cycled in every 3 weeks, or it'd be 3 weeks in, and they could have 1 week out, so that way they'd have a withdrawal period associated with that. So it's another dosage form you can see there. This could be placed by the patient. Again, they would just take it out after that 3 weeks. If it comes out early, they can put it back in, no problem. There are implantable ones as well. Here's an example of an estradiol, which is implanted every 3 years. So it could be one option for patients there. Again, irregular bleeding is going to be a little bit more common with this one, just because it is only progestin based. And then here's an example of a non-hormonal contraceptive, which I think is really interesting, utilizing copper. So this is called Paragard. So it's a copper intrauterine contraceptive here. And basically, it kind of slowly releases these copper ions that helps to impair that implantation and sperm transport. The sperms really just don't like having those copper ions there. And this one is nice because it lasts for 10 years or so. The only thing to be concerned about, and this is something that you may have to like kind of go back for after an IUD is placed, you can have a rare case where you can have translocation of the IUD outside of the uterus and into the abdominal cavity, and that could be a big issue. But it's pretty rare, but that's why you may see that patients will get this placed and they have to go back like in a week or two to make sure that it's still there. They can use either physical exam or ultrasound to make sure where it's at. So pretty cool stuff. Just to wrap up a little bit here is going to be our inhibitors and antagonists. We're going to see several different places where we can introduce medications here to inhibit the production of things like estradiol and progesterones in order to decrease activity for things like breast cancer that's responsive to estrogen and things like that. So first off, I'm going to talk about the SERMS, or the selective estrogen receptor modulators. And the first one that we had here was tamoxifen. And this is basically going to be a partial agonist at certain types of estrogen tissue. So for instance, here it's going to be an agonist in both the bone and in the endometrium, but it's an antagonist in the breast tissue. Not the most ideal thing, but it could be okay if you had someone who had a history of a hysterectomy, for instance, and high-risk breast cancer. Again, why it's working in these different tissues is probably related to something with the receptors that are there in the nucleus. But this could be used for like palliative care in breast cancer patients, or if they're really like high risk history of breast cancer, then they could use this as well, because it could still act as an antagonist in the breast tissue, but then still act as an agonist in the bone. So you don't have the osteoporosis risk you're going to see with some of the other agents here. Again, you're going to see symptoms of menopause pretty commonly with this, so things like hot flashes and vomiting are pretty common for the most part. And again, the benefits here are especially on the bones. So we're going to see prevention of loss of things like lumbar spine bone density, which is great. You're going to have better changes in their lipid profile because you're going to get some of the positive estrogen effects on the liver there. However, we did see increased risk for things like endometrial cancer, so that may not be good if they have an intact uterus. And you can still see some thromboembolism risk associated with that. So not an ideal drug, but could be useful in some certain circumstances. Instead, you have things like raloxifene that can be used. This one's going to be nice because it'll have estrogenic effects on the lipids in the bone, but it doesn't stimulate the endometrium or the breast tissue. So again, you can either see this here for postmenopausal osteoporosis, where you don't want to give estrogens that can stimulate some of these other tissues, or prevention of high-risk breast cancer. So that'd be one thing to consider. Not high-risk omen, should be high-risk women. But other drugs here include things like clomiphene or Clomid. This is going to be a partial agonist here. This actually binds up in the hypothalamus, and it will sort of disrupt the feedback loop that normally estrogen would sort of inhibit ovulation from occurring, and so you can actually use clomiphene to stimulate ovulation. So this is one of the first drugs you'll see being used for infertility in a lot of cases there. So by disrupting that, it's going to be able to help to release things like LH and FSH and cause ovulation to occur again. Then we have some estrogen antagonists. So again, you can imagine some of the side effects we're going to be seeing with this. This is going to pretty severely suppress ovarian function. It will help to inhibit things like LH and FSH surges there, and is used frequently to treat things like endometriosis. You can see some other conditions too, things like Christmas disease or ITP. Again, the full mechanism for why that occurs is not really fully understood with that. But again, you can see here, because you are having a weak or estrogen antagonistic effect, you're going to see things like decreased breast tissue size, but you're also going to be seeing things like more testosterone-like activity. So you can get more acne, more hair growth, and deepening of the voice because you're going to be suppressing estrogen activity pretty significantly, and thus you're going to get a commensurate increase in the androgen activity. It's not great. Then we have our aromatase inhibitors. So these are going to be really useful to drop down estrogen levels pretty significantly. These are typically used after the SERMS have failed, especially for things like breast cancer. These are going to be way more side effect prone because they're going to be dropping your levels of estrogen quite significantly. And thus you're also going to be seeing a lot more testosterone effect because the testosterone can't be converted over into estrogen because of the aromatase enzyme is inhibited. So a few here, we have things like anastrozole, letrozole, and then exemestane. Exemestane is even worse. You can see like 90% reductions in estrogen levels because it is an irreversible inhibitor. So you have to actually produce new aromatase before you can even start to convert any of that stuff over again. So fewer proestrogenic effects and things like tamoxifen, more risk for fractures, obviously. So that's why it's used for more very treatment-resistant disease in those cases there. So sorry, that last bit was a little bit quick. I just want to make sure I got through that to see if you guys had any questions. What do you guys think? Anything at all? So your homework assignment will be due next week. That's going to be on the outpatient medication orders because it's like you're writing for like a new diagnosis diabetic patient. So it's fine there. Remember with your insulin doses, don't get super granular in terms of making sure that every dose is like evenly divided out. So I don't want to see like 3.6795 units given at lunch. Like that doesn't make sense. Like just do whole units. Just make sure the total daily amount makes sense based off the weight of the patient and all of that. So, excuse me. What questions do you have for the exam? Any question on the sticky board either? So, and if you have questions, I mean, feel free to email me up to the day before the test. I mean, like I'll take questions whenever. If you email me. I think your test is on Thursday. So if, you email me at, 1 a.m. on Thursday morning, I'm probably not going to get back to you. But, certainly during Wednesday, I shall. Yeah, so Madeline's asking for oral contraceptive. How fast is the onset of action? So, assuming you mean for ovarian suppression, again, it's fairly quick. I mean, but that's why some people will say, well, go ahead and use backup contraception for the first month. Using condom or something like that, because, some people worry that, okay, well, it's not going to kick on right immediately, but like, when is it really going to be most effective? I don't know. We have a good idea of that, but I think for the most part, you're mostly protected, during the first month there. But again, if you're looking at the risks versus benefits of using backup contraception, the risks are quite low, right? Maybe an inconvenience, but that's about it. Versus the risk of an accidental pregnancy, I'd probably err on the side of caution for a lot of these patients here. So even like the antibiotic thing, like that's probably not. I mean, how many pregnancies have been caused by antibiotics? I have no idea. I don't know if we're ever going to know that. It's probably pretty low. But again, what's the risk of using a backup contraception? Not a whole lot. What other questions do you have? And you can talk about any of the materials. So anything from geriatrics, endocrine, nephrology, urology, OB-GYN. Close that out. Hopefully my child was not too noisy. She's been very good. Being quiet back here. No questions. Either everything is so solidly in your mind that you have perfect knowledge of the topics, or you haven't studied it yet. I understand. But yeah, if you don't have any questions, feel free to log off. See if you people have already. That's fine. I'll stay on for a minute or two and see if you guys have questions. Here we go. So someone was saying, is 3.5 units of insulin okay, or would you rather 4 units? So that's dependent if they can get syringes that have half units on them. I think the vast majority I have found have just been whole units. If you wrote 3.5, I probably won't give you too big of a hassle for that. I think most people will try to round to whole units whenever possible because I think it's just more common. So. Let's see. So, Christina's asking, does exemestane block estrogen receptors? No. So, exemestane blocks the aromatase enzyme, so it prevents the conversion of testosterone over into estrogen. So, it doesn't do anything to the receptors; it just blocks conversions. That's why your levels of estrogen drop down so significantly, like 80 to 90% or something like that. Oh, Sylvia, I'm glad you appreciated Pharm. Yeah, I think a lot of people come into pharmacy school and they hear a lot of bad things, or they come to PA school and they hear a lot of bad things about the pharm courses. But hopefully I've made it at least a little bit bearable for you all. Sorry I didn't get to meet any of you guys in person. Like it's kind of a bummer, but no, I don't have any insulin calculations on the exam. More so like drug selection or looking for side effects, things like that. It's more so what I'm be asking. It's been a very weird year, but hopefully you guys don't feel like you've gotten too much short shrift. I feel like I've been able to give a pretty similar sort of, experience to what you would get if you're in the classroom. Obviously, I think, sort of impromptu interactions are easier when you're in person than online, but hopefully this has worked out well for you regardless. Oh, God, I'm glad you appreciate it, David. Thank you. Happy to have taught you guys. Yeah, good. I'm sure you're going to do great on rotations, and remember, it's even if you have questions that pop up during rotations, like I don't stop being your teacher just because you're not in my class. So if you see something weird or you're just like, hey, I had a question about this that comes up, like feel free to reach out. I have no problem with that. I have people that still do that even if they graduate. Hey, I saw this thing. What do you think about that? I have to keep in touch with you guys because again, you might be my coworkers one day. You never know. Maybe I'll work at Florida Hospital or something one day. All right. So, yes, thank you. I'm going to go ahead and hop off, but if you have questions, feel free to email me up until, Wednesday night. I'll try to get back to you as soon as I can. We'll go from there. Have a great weekend. See you later.